Good morning, good afternoon, good evening. We're just giving folks another few minutes to sign in, and then we'll officially get started. Welcome, good morning, good afternoon, good evening. We'll be getting started shortly. We're just going to give folks another minute. We know that there's been some network issues depending on the state, so we'll get started in about 1 more minute. Okay, I'd like to hand it over to our esteemed moderator, Ms. Nyoma. The floor is yours.
Good afternoon. Thank you for joining this webinar hosted by the Challenge Initiative. At this webinar, we will be discussing how states in Nigeria are adopting and implementing high-impact interventions introduced by the Challenge Initiative to improve delivery of family planning services in the states. Before we talk about these service delivery interventions and the efforts made by states to adopt them, let me introduce the Challenge Initiative. Using a business unusual model, the Challenge Initiative helps states in Nigeria to execute proven to work reproductive health solutions. TCI works in 12 Nigerian states, where it provides support to the state governments to implement reproductive health solutions. The initiative's interventions are focused on 3 major areas. They include advocacy, demand generation, and service delivery. Adolescent youth sexual and reproductive health programming is embedded in TCI's interventions across all the states where we work. TCI also has an integrated research monitoring and evaluation unit, which provides evidence and direction on areas for intervention in the states. On today's webinar, we will be discussing how states in Nigeria have adopted high-impact interventions introduced by TCI to improve family planning service delivery, and the steps that were taken by the states to adopt and implement these interventions. In the course of this webinar, we will be introduced to TCI's service delivery interventions and learn why adoption and replication of these interventions by state governments is important. We will learn about the high impact interventions that have been adopted by state governments and the reasons for adoption of these interventions. We will also learn about the challenges faced by the states in adopting these interventions and receive tips for successful adoption and implementation of these high impact interventions. We were supposed to be listening to 3 speakers during the course of this webinar. But unfortunately, two of the speakers are having issues connecting to this webinar because of network problems in Nigeria at the moment. But we were supposed to listen to Mrs. Confidence Oboso, the family planning coordinator at the Abia State Ministry of Health. We were also supposed to listen to Mrs. Rahila Telfim, the family planning coordinator at the Plateau State Primary Healthcare Development Board. And we are able to reach and we'll be listening to Dr. Ememobong Jaja, who is the MNCH focal person at the Rivers State Primary Healthcare Management Board. Before Dr. Ememobong Jaja takes the stand to talk about Rivers State and the service delivery interventions that are adopted and implemented, we will have Dr. Deborah Samaila. Dr. Deborah Samaila is the state program coordinator, is a TCI state program coordinator in Nasarawa State. She will be giving us a brief introduction to TCI service delivery strategy. Dr. Deborah, please.
Okay. Hi, everyone. So the service delivery strategies are aimed to achieve two main goals. And these goals are to increase access to family planning and adolescent and youth-friendly health services, and also to improve the quality of family planning and adolescent youth-friendly health services. Some of these strategies are mostly cross-cutting. That is, a strategy can be able to increase access and at the same time improve quality of family planning and adolescent youth-friendly health services. So the strategies employed to increase access to family planning and adolescent youth-friendly health services include integration, reach, and FP, family planning method mix. Integrating FP into other services and into other services in the facility and community is done both intra-facility and also at community level. Intra-facility, it means that these services are being integrated into other service delivery points. And family planning, the clients are being told about family planning so that they can be able to know whether they will need their services or not. Enriching the underserved, facility-based enriches are conducted in facilities with low volume or facilities that do not have trained family planning providers. Also, through wholesale orientation, where clinical and non-clinical facility staff are oriented on a monthly or quarterly basis on family planning and adolescent youth-friendly health services. The use of quality improvement team comprising of facility staff and community members to serve as linkage of communities to services in health facilities are also ways in which we reach the underserved. Others are through ensuring quality referrals, task shifting, and so on. And also commodity security is also one of the ways to ensure that women are being reached with family planning and also services are being provided without interruption to clients. So the strategies employed by TCI to improve quality of family planning and adolescent youth-friendly health services include ensuring the environment for service provision is conducive to both the client and service provider. The service provider is also equipped with all the necessary knowledge to provide quality services, that's through capacity strengthening. And also there are availability of tools to ensure continuous learning by the service providers and documentation of these services provided to clients. So in enabling environment is assured through the following: assessment of gaps in the facilities on family planning or adolescent and youth-friendly services, and drawing up plans to close these gaps, which is done through the performance improvement assessment and performance improvement plan. Then the wholesale orientation ensure both clinical and non-clinical facility staff are knowledgeable on the importance of family planning and adolescent youth sexual reproductive health services. Then also The QIT ensures that the community and the community is linked to the facility, and then that committee ensures that quality of services are being provided to clients. Then also we use 72-hour clinic makeover to ensure that the infrastructure for service provision is intact, and also there are availability of standard equipment in the facility for service provision. We try to address provider biasness towards service provision to clients using the client-provider dialogue, and also adherence and use of SD policies like the tax shifting, tax sharing policy ensures that the environment for service provision is being enabled and conducive. Then for capacity strengthening, this is done through competency-based trainings on family planning, adolescent youth, sexual reproductive health, contraceptive logistic management system, interpersonal communication and counseling, through employing the training of trainers, step-down trainings, and on-the-job training. Then also we build capacity of service providers through mentoring and coaching visits and supportive supervision visits, which are carried out on site to build the capacity of these providers where necessary. The tools employed to ensure proper documentation and continuous learning can be in the form of the distant learning education application, such as the Get It Together distant learning application, which is called My Family Planning Guide. This provides opportunity for the service providers to keep on learning how to conduct the family planning services. Then we also have the HMIS tools like the facility family planning registers, the daily consumption registers, the monthly summary forms, which are used by the service providers to document the services that are being provided. Then we have manuals that the service providers can use in training and also during the on-the-job training. Then there are availability of guidelines like the 72-hour makeover guideline, the counseling guideline, the client provider dialogue guideline, which the service providers can refer to at any time to give them the opportunity to understand more on how to perform these services, and also to guide them in carrying this, in implementing these services. So why is it important for state government to adopt and replicate these service delivery high impact interventions? So these interventions are not only assumed to be high impact interventions, but they have been proven to work. And also these high impact interventions are cost efficient and easy to replicate with little or no much technical support. Replication ensures diffusion of learnings across the entire state, leading to statewide improvement in the family planning indices. And finally, when these high impact interventions are adopted and replicated by state government, sustainability beyond TCI is assured to a larger extent. Thank you for listening.
Thank you very much, Dr. Deborah. We will now go to River State, where we will listen to Dr. Ememobong Jaja. Dr. Jaja is the maternal, neonatal, and child health focal person at the River State Primary Healthcare Management Board. She actively provides coordination, technical guidance, and oversight to design and implement maternal and child health interventions to improve maternal and child health outcomes across all 23 local government areas in River State. Dr. Jaja, please.
Good afternoon, everyone. It's good to have you here, and I'm pleased to be here this afternoon. So I'll be making a presentation on the challenges to adopting the service delivery interventions and tips for successful adoption and replication of these strategies as we have seen it work for us in River State. We'll go on to talk about our background. River State is located in the South Nigeria with an approximate population of 8,280,753 persons. This is an estimated population from our 2006 estimated population. And our women of childbearing age, of reproductive age, is about 1,821,766. Our contraceptive prevalence rate is 32% currently. Our modern contraceptive prevalence rate is 19.6%. The women not using any form of family planning method is 68%, and our unmet needs is 23%. TCI currently is being modeled in 12 out of 23 LGAs in our state. That is 52% coverage. And in our 319 family planning facilities that provide services, TCI is supporting 52 out of these, which gives it a coverage of about 16.3%. And our funding sources are the government, our partners, which TCI and other implementing partners are part of them. So for us, the high impact interventions that TCI brought on board, which has been quite interesting for us as a state, includes the 72 hours clinic makeover, which is a very interesting intervention in which in 3 days, a particular client is in a facility, and by the time the client comes back on a Monday morning, the facility is entirely changed. Within 72 hours, there is an entire makeover of that facility. The commodity security to ensure that we do not have stock out of commodities. We have a complete family planning method mix at all times. Our whole site orientation and quality improvement teams, where we have orientation of all healthcare providers in a facility, beginning from the security man at the gate to the cleaner in that facility to the laboratory provider. Everyone is oriented on the benefit of family planning, and no one sends away a client right from the gate. We also have our competency-based training, the on-the-job training, our performance improvement assessment and performance improvement plan, which serves as a baseline platform for us to know where we were, where we are before we start up with interventions and strategies. Then we also have the family planning supportive supervision checklist, which we use to ensure family planning quality improvements of services at all times. And we have had this family planning supportive supervision checklist being incorporated into the state quarterly integrated supportive supervision. Then we also have our facility based enriches, where we go out and create demand and bring the clients to the facilities. So for us in Rivers State, we've been able to adopt some of these strategies, these key strategies, and one of which we have been able to adopt for ourselves as a state is the whole site orientation. This whole site orientation is quite interesting for us, where everyone in the facility is brought on board and is well conversant with what's happening in that facility as it concerns family planning services, sexual reproductive health. Then we also have the family planning supportive supervision, which is done monthly, done through checklists, through the e-platform also. And then we also have the quarterly integrated supportive supervision, which family planning supportive supervision checklist is also incorporated into our commodity distribution and security to ensure that we do not have stock out at any time, and our facility-based enriches. Now, these programs, we've seen these strategies work for us as a state and some of our key program results. Looking at our client flow, right from when TCI came into the state in June 2018 to July 2020, there has been an increase in our client flow. There's been an increase, about 188% increase in our client volume, which is about 31,597 more clients have been able to visit our facilities, the 52 facilities where TCI is being modeled and is supporting. And this has been due to the fact that we have been able to adopt some of these high impact interventions. So the state we've been able to appreciate this cost-effective way of generating demand and service uptake. We've also improved on integration as a benefit of adopting the whole site orientation between our non-clinical and clinical providers, and then the adoption of the family planning supportive checklist into the state's quarterly checklist, integrated supportive supervision checklist. Now, adoption of some of these high impact interventions have not been without its challenges. So some of the challenges that we have experienced in adopting some of these high impact interventions includes the fact that decision based on initiatives yielding immediate short-term results and outcomes has been one of the challenges, where our decision makers sometimes they just want to see the short-term, they want to see initiatives or interventions that provide very short-term results and outcomes. We know that when it has to do with health outcomes, you might not see them immediately, but with time you will be able to appreciate the result and the outcomes. Then the issue of we have various implementing partners in the state. So the multiple family planning strategies projected by the different partners has also been a source of challenge for us to be able to focus on one which we are working on seriously as a state. The standardized procurement process has been a challenge for us in fully adopting the 72 hours makeover. We know that with TCI, with the 72 hours makeover, we use local artisans to be able to get work done in no time. But for us as a state and as the government, you need certain standardized procurement processes to be able to get that work done like that. We also have the reluctance of government staff to encourage adoption of strategies for fear of additional burden of work. We see here where we do not have enough manpower, enough personnel to do the work, and so they are afraid of an additional burden in terms of adding on new strategies. The inadequate domestic funding and release is also there, where we do not have enough funds being released for family planning services. The mindset growth in accepting new ideas, both at the facility level where the providers provide services, even also at the policymakers level. And so we have a lot of work to do around mindset growth in accepting new ideas and new strategies. And the vertical planning and implementation of health programs is also one of the challenges. We have some tips for going forward that we have tried to bring up. And so for us as a state, the tips for going forward to be able to adopt most of these interventions are the continuous reinforcement of service delivery strategies at different levels, at the local government staff level, the technocrats and the policymakers. We've come to realize that the more people hear about a particular strategy and intervention, the more it gets down better and it's easier to adopt. Then the use of data as evidence to engage decision makers on the benefits of adoption, as well as the consequences of inaction or non-adoption of some of these strategies. We play around data a lot. We use data for decision making. We use data for advocacy. We also, there should be also continuous periodic feedback to government, keeping them up to speed with implementation and linking family planning as a tool for socioeconomic growth and development. We cannot but see that family planning services, if it's well provided, well adopted, it is a major tool to improve socioeconomic growth and development in a state. We also ensure that we have our activities embedded in our state strategic health plans, our annual operational plans, our work plans, our guidelines. If we do not have these activities embedded there, there is no way we can actually implement this strategy. So we need to be sure that our strategies, our activities to implementing these strategies are embedded in all our work plans and in our annual operational plans. We also try to show the work that we do. Whatever we do, we make it evidence by giving feedback to show that this is working, just like we have seen in the outcome slide. Then the effective coordination and synergy between partners that facilitate government ownership and adoption of strategies, which the government, for us at the government, and we are trying to ensure adequate, effective coordination of our partners. We also intentionally integrate and link multiple health programs for the best use of available resources. We've discovered that carrying on with parallel activities, parallel health programs is not the best for us with the limited resources that we have. So we intentionally integrate family planning into other health programs and ensure that we make best use of our available resources. We also identify and engage champions within relevant ministries, departments, and agencies that give insight into political budgeting, finance, and processes to be sure that we have people always advocating for family planning at every point in time. Improve the human resources for health. We discovered that if we do not have enough workforce, enough manpower, it might be a little difficult to adopt all the strategies. So we are working on improving of these human resources through employment of more staff. We strategically identify issues decision makers are concerned about, and we try to advocate on those issues and put them right. We also address the mindset shift and change at all levels using coaching strategy. And then the increased advocacy for policies that can enable the redistribution of financial resources to meet most of, if not all, of our family planning interventions. For us in the Rivers State Primary Healthcare Management Board, we have a permanent secretary. His name is Dr. Agriye Hari, who is very passionate and very supportive of family planning services in the state concerning family planning, and we can see most of them we are adopting. And how you can know it is that most of what we do nowadays in terms of planning, whether it is family planning or not, are part of it, is well appreciated. I would like to say that we need to make work fun, we need to make it easy and exciting, and that way adopting of more of our high impact interventions will be fun. Thank you very much.
Thank you very much, Dr. Thank you, Dr. Jaja. We will go now to Abia State, where Dr. Ikechukwu Opara will be presenting on behalf of Mrs. Confidence Oboso. Dr. Opara is the TCI Service Delivery Technical Support Lead in Abia State. Dr. Opara, please.
Okay, good afternoon. So I'm representing Mrs. Oboso Confidence, the State Family Planning Coordinator, Abia State. She couldn't join us because of internet challenges. So overview of TCI in Abia State. TCI represents a platform which demonstrates tested and proven and replicable interventions that improve family planning, interventions, and uptake in the state. TCI in Abia commenced in June 2018, and we started with 9 LGAs out of the 17 LGAs. Inside the 9 LGAs, we're demonstrating in 36 high volume sites across the 9 LGAs. The TCI Abia State team, through their technical support, coaching, demonstrated high impact interventions in service delivery, which Abia has successfully adopted and replicated some of them. So some of the high impact interventions adopted and replicated by the state include the family planning in reaches, which we usually call the game changer, because we've noticed that it has been giving us so much results with little effort and resources. We have the coaching and mentoring that the FP supervisors and the master trainers do routinely. Then we have the on-the-job training that we usually leverage on in-reaches to do. So we use it to increase the capacity of to build the capacity of service providers, as the state have, what I say, one of the lowest number of trained nurses on LAC. So we leverage on in-reaches to build their capacity on this. Then the 72-hour clinic makeover. The state, for the first time over the past 3 months, have renovated about 10 facilities. And these are the 4 basic high impact interventions that the state has adopted and replicated. Next slide. So we want to look at the synopsis of these high impact interventions. When it comes to family planning in-reaches, in September 2020, in-reaches reported over 2,000, the state reported over 2,000 new acceptors on LAC in about 64 facilities. This was actually one of the biggest new acceptors we could have in a single month, all thanks to in-reaches. Then the health facility renovation, about 10 facilities were renovated across 7 LGAs by the State Primary Healthcare Development Agency since February 2020. On the on-the-job training, we leveraged on in-reaches to conduct OJT for nurses and CHUs. We usually, for CHUs, we usually concentrate on SAC. For nurses, we concentrate on LAC until they pass the TSTS for the state. This has also increased the pool of facilities now offering and reporting LAC services. For coaching and mentoring, the FP supervisors in the state, together with the master trainers, now go on routine coaching and mentoring visits to facilities in their LGAs in order to strengthen their capacity and also close identified gaps. So we want to look at the reasons for this adoption. What actually made these high impact interventions attractive to Abia? The first is active community participation. We notice that this high impact intervention has a way to incorporate the community people, and it brings ownership because the community members are all involved. Then there's ease of implementation and application. It doesn't really cost much. With little resources, you could do enriches instead of, and the results are usually massive. Then you have improved facility environments. Activities such as family planning, 72-hour makeover has a very big impact on the environment, where you now have a very neat facility that attracts clients. Improve quality of service provision. With 72-hour makeover also, with capacity building, you have service providers who can give quality service to clients. And when a client is satisfied, it usually leads to usually call it client-induced advocacy, whereby the satisfied clients tend to bring someone else to come around. The cost effectiveness and sustainable. The high impact interventions are very cost effective and they are very sustainable. As I just mentioned, that you need minimum funds to do them, and it makes it sustainable because even some facilities can fund it without waiting for the government directly to do that. There's increased uptake of family planning by women of reproductive age. From what I've just said in enriches, we notice that enriches have been giving us so much figures. So all these reasons made us to feel that we can replicate this and it can give us good results with the principal aim of having a satisfied user. Then we want to look at the process of adoption. So in the process of adoption, we started with analysis of data and results from implementation of the high impact interventions. Data from facilities that TCI are demonstrating in were presented to the stakeholders, the policymakers. They saw that this is not just pictures, that there's actually results. So from there, we now presented these results to the policymakers, that's the State Ministry of Health, the Abia State Primary Healthcare Development Agency. Then from there, they developed a budget to support the scale up and replication of the high impact across other across other facilities and LGAs. Then budget for the activities were all developed and approved by the policymakers. Then the implementation proper. So in conclusion, implementation of these high impacts have become a norm, and the state is willing to further scale up interventions to other LGs that is not yet saturated. Enriches, which has become a common name in most facilities across the state, is seen as a game changer because with little effort and resources, many new acceptors are reached. And this has actually skyrocketed our new acceptors since we started replicating these interventions. Next slide. Thank you very much.
That was Dr. Ikechukwu Opara on behalf of Mrs. Confidence Oboso, the Family Planning Coordinator at the Abia State Ministry of Health. From Plateau State, Nigeria, we will now listen to Rahila Telfin. Rahila is the Family Planning Coordinator at the Plateau State Primary Healthcare Development Board. She coordinates the implementation of family planning service delivery in all 17 local government areas of Plateau State. She has also worked as a family planning service provider for about 20 years and has passionately contributed her quota in scaling up access to family planning services for youth, women, and men in the state. Rahila, please.
Thank you for having me. Good afternoon, everyone. Next slide, please. Plateau State is located in north central Nigeria Plateau State is out of 17 local government senatorial zones. The State Ministry of Health created family planning units under the Maternal Health Care Department in 1976 and is still existing at the State Primary Care Board. TCI came to the state after a expression of interest by the state in 2018. Thereafter, TCI service delivery approaches were introduced to the state and local government stakeholders via various capacity strengthening platforms. The last speaker spoke about two modes of service delivery, improving quality and increasing access. For Plateau State, we have adopted all these goals, even included them in our annual operational plan. So let us talk about improving quality. For improving quality, family planning supportive supervision has been adopted for implementation during integrated supportive supervision across the GS in the state. I found out that our integrated supportive supervision tool is not rich enough to cover all the service delivery components for family planning supportive supervision. Performance improvement assessment has been replicated across all the 17 LGS, and then the service delivery tools like the on-the-job training manual, counseling, infection prevention job aids, and even online resources like the TCI University Family Planning Guide has also been adopted for use by service providers in the state. Quality improvement team is incorporated into the existing village development committee. One of the interesting strategies the state has adopted is 72-hour clinic make, which has been replicated in some local government. Job training has been institutionalized as it is a cost-effective strategy for capacity building of front health care workers. Talking about improving uptake, these are some of the strategies that is also have adopted and using integration. We carry out integration, intra-facility, within the facility, and even community integration, whereby demands are created and clients are referred to the facility to obtain services. Thereafter, we have seen improvement in reporting, intra-facility reporting, and even the community level in their records of our service providers. Site orientation has been adopted and even modified to be expanded orientation, which will now include the patent medicine vendors and all the others community influencers. We have also adopted inReach to help improve our uptake of service delivery state, whereby capacity of service providers are being built, and we watch them as they reach into competence that will determine their certification as service providers. Before the coming of TCI, AY plans was separately conducted. However, with the coming of TCI, we have adopted a of state life planning ambassadors whose service delivery activities such as quality improvement team and during the enriches. We have also adopted support of facilities service delivery outlet, the patent medicine vendors, and also community resourcing. They map out and they link with the facility, inferring service providers, most especially the adolescent to access services in the service delivery points. As a result of all these approaches that the state adopted, we have witnessed rise in 35% increase in the total family client volume, as I see from this graph, and also an increase in our current contraceptive rate to 22.7% against 17.4%. The drivers of all this impact include facility enriches I've mentioned, the outreaches, the whole site orientation, and even integration. Okay, we learned. We have learned that adopting the delivery approaches has greatly helped this to save time, to save cost, and also improve quality of family planning services and improve sustainable community participation as outlined on this slide. We have also learned that for a state to effectively carry out all these approaches, quarterly reproductive health coordination meeting is a low-hanging fruit that puts adaptation and integration of service approaches across other non-TCI areas, including the use of coordination platform, the youth technical working group, family planning technical working group. Again, the use on the job training manual and the visual platform for capacity building has compared to the normal classroom approaches has witnessed to cost-effective and efficient way for replication of service delivery approach across the state. Finally, we have also noticed that Plateau State has learned that adopting this service delivery strategy is less cumbersome, less difficult, and easy to implement. Thank you for listening.
Thank you to all the speakers. Thank you to all the speakers for your presentation. Once again, I want to apologize for the mild network problems that we are experiencing. We are moving on to questions and answers. Okay, we have quite a few questions. And I would like to start with this very direct one from Mamadou Kanji. Mamadou wants to know which of the high impact interventions contributes to increase in number of FP users. Which of the high impact interventions contributes the most in increase of number of FP users? I will direct this question to Dr. Jaja from River State. Dr. Jaja, which of the high impact interventions?
Thank you for this.
Okay, thank you very much, Norma. I think for us as a state, as River State, the particular strategy that yields a whole lot of increase for us is the facility-based enriches. During the facility-based enriches, what we do, we basically go out to the community, create a lot of demand, and then we see the needed response back at the facility where the clients just come in their troops and then they provide all the needed, and we provide services to them. So for us, the facility enriches is facility-based enriches is one of our.
Thank you, Dr. Jaja. The next question has to do with the sustainability of the 72-hour clinic makeover. Abubakar Yaya wants to know if the 72-hour clinic makeover will be sustainable and if governments in states have shown any commitments to carry out renovations in the planned scale-up? I will direct this question to Dr. Opara from Abia State. Dr. Opara, can you respond to Abubakar Yahaya, who wants to know about government's commitment in scaling up the 72-hour clinic makeover model to other communities?
Okay, thank you very much, Noma. So for Abia State, I know for most states, there's what they call the Basic Care Provision Fund that the federal government, together with World Bank, have with the states. So in that Basic Care Provision Fund, we noticed that most facilities have money for renovations. So we try to provide medical assistance for them to know how they can leverage on that money for renovations to get facility renovations for 72-hour makeovers. That is what the government also leverage on to make the first 10 facilities that they renovated. So since the Basic Care Fund provision is kind of sustainable because it's a state federal government partnership, so the state, we hope that the state will leverage on that to be making the renovations for now until there is now a particular budget for family planning that can now be used for those renovations. Thank you.
Mrs. Rahila Telfim, I have a question for you. And the question is, how would you in Plateau State ensure sustainability of these high impact interventions beyond TCI's period of support? How would you in Plateau State ensure that these high impact interventions are sustained beyond TCI's period of support?
Okay,
Rahila?
thank you very much for this very question. For us to be able to sustain all these high impact intervention Plateau State, just as mentioned, because most of these high impact intervention, they save time and they are cost effective. For example, if I am out OGC for my service providers, I know I will spend less money in doing that, and then I will give service provider the right quality of skills they need. And for the state, we find out that most especially OJT is something that would really sustain.
Thank you, Rahila. Dr. Jaja, I have a question for you. Dr. Jaja, please, can you explain to Sarah Jane the necessary sequence of activities in integrating FP into other health activities? So in integrating family planning into other health activities conducted in Rivers State, what is the necessary sequence of activities?
Okay, thank you very much. So for us in Rivers State, what the sequence we followed to integrating of these activities, we first started with the performance improvement assessment, where we went to the facilities, assessed to know the level at which we were, and then we started orienting the healthcare providers at that level on the various interventions that we had on board and how we're going to establish how we're going to begin to use these interventions in a cost-effective manner to improve on our service uptake. And we made it very simple. We made it very straightforward. We didn't make it look cumbersome in any way. And then at the state level also, we tried to use every opportunity we had. It was more like an advocacy opportunity every time we had an opportunity to reinforce on the available SD strategies and to talk about how cost-effective these strategies were. And I think that is one of the things that created the enabling environment for these high impact interventions to strive in our state. Thank you.
Thank you, Dr. Jaja. I have another question. It says, did you see uptake in other health services beyond the documented uptake in contraceptive use? And I think I would direct this question to Rahila, and I would direct it to Dr. Jaja, and I'll direct it to Dr. Opara. So from all the three states, I would like to find, Oyin wants to find out from you, did you see uptake in other health services beyond the documented uptake in contraceptive use. I will go to Dr. Jaja first.
All right, thank you very much. When we began creating a lot of demand, because we did a lot of work in demand creation and generating of demand right from the community. Now, when we discovered that when the clients came to our facilities, yes, they came in and they got the family planning services that they heard in the facilities about. And then they also had opportunities to receive other services that sometimes they felt they didn't have enough time to make out, to come to the facilities to receive. So when they came, some of them came with little babies and they used that opportunity to immunize their children. Some of them also came and discovered, oh, I've not yet done my HIV test. I need to do it. We talk to them. You know, we normally have this health talk that we have where we speak to, we carry out health education promotion activities where we talk to our mothers and clients, caregivers while they are seated and waiting for services to start for the day. And in that particular session, we introduced a whole lot of health topics to them, and they used the opportunity of coming in for family planning services to also reach out to and receive other health interventions. In as much as we didn't show those outcomes in our slides, but I can tell you that from our reviews, it was not just family planning uptake that increased, our general attendance in the facility increased, our other uptake of services also increased. Thank you.
Very interesting, Dr. Jaja. I will go to Rahila. Rahila, did you see uptake in other health services beyond contraceptive use?
Yes, thank you very much for the very question. Services like in the area of immunization and health orientation, and even the adolescent youth accessing services like we have noticed that they go out to the PMVs or even to the private access all these services. But now the adolescent come to the facility to access service like SI care. In the past they don't do.
Thank you, Rahila. Dr. Para.
Okay, thank you very much, Noma. For Abia, actually we've seen that this high impact intervention not just only touch family planning, it also have effects on other services. For example, in a facility like World Bank PLC in Omaha North, we had the 72-hour makeover. We noticed that after the 72-hour makeover, the OIC gave us a success story that the number of women that comes for labor and delivery has increased. The immunization, under five treatments, everything has increased. The clientele have increased in the facility because the people now see the facility as, according to her, that is now attractive to clients, that even the state now uses her facility for public health posting for doctors. So it has a way of attracting clients because the facility now looks neat. Then for high impact intervention like Enriches has a way for most of our facilities, how it has a way of increasing the clientele. So when you go and enrich for a low volume facility, you notice that a facility that is used to having 5 or 10 clients in a month can now start having up to 20, 30. And this has a way to boost the revenue of the facility and also increase the clientele in other service delivery area. So for Abia, I think it has a ripple effect outside family planning. Thank you.
But I am back.
Hi, Nomar, you back? Great.
Okay, thank you, Dr. Para, for answering the last question. I want to now ask the panelists, all the panelists, about adaptation of these high impact interventions given the COVID-19 pandemic. Which of these high impact interventions have you adapted in response to the COVID-19 pandemic? I will start from Dr. Para. Dr. Para, which of the high impact interventions did you adapt for use in response to the COVID-19 pandemic?
Okay, I think all those 4 high impact interventions, like when we are conducting enriches and coaching and mentoring, we usually stick to the state guideline on COVID-19, the social distancing, use of face masks, hand washing, and use of hand sanitizer. So even clients are also told that as they're coming to the hospital, they ensure that they have their nose masks. If not, they won't receive treatment. So most clients already know that as they are coming there, they are already coming with their face masks. So we try to also, when we're having our meetings, we try to stick to the number the government gave us in a hall and ensure that everybody maintains their social distance. Thank you.
Thank you, Dr. Para. Rahila, please, can you tell us which of the high impact interventions helped you in your COVID-19 response?
Thank you very much. During the COVID-19, the first thing we were able to do most of our trainings and even some activities, service delivery activities on visual platform. Because this is a platform that will be able to reach all the service providers. Then during the COVID also, clients were able to come out, but immediately were able to organize enriches. The state was able to give consumables that will help in the conduct of the enriches. A lot of clients turn up to access services. So we are able to use online platform to render services to our service providers in the various communities they are. So all this also helped us during the enrich to carry out our services, even staying to wait until after the lockdown.
Thank you, Rahila. Dr. Jaja, talk to us about the high impact interventions and your COVID-19 response in the states.
All right, thank you very much. During the COVID-19 responses we had as healthcare providers, we did a lot of training during that period, trying to bring our healthcare providers in the facilities on speed with COVID-19 infection and infection prevention practices. So we made sure that we introduced all the key during the trainings. We brought the benefits of family planning. It was more like an opportunity to carry on with whole site orientation because the trainings were made for all the healthcare providers in the facility. Then when we were also mobilizing at the community level, we did a lot of community mobilization during the COVID-19 period to tell people about the signs and the symptoms and what is expected, where they should go to the healthcare family planning, that during the lockdown, if they are not careful, we'll be having lots of unplanned pregnancies, and we're providing services. And we had a lot of clients visit us even during the lockdown. We also made sure that we had our reproductive health coordination activities. We had them virtually. Even our family planning supportive supervision did not suffer during this time. We did them using our electronic platform. So basically none of our high impact interventions really suffered during the COVID-19. We try to integrate them with all our activities. Thank you.
Thank you, Dr. Jaja. Thank you to all the speakers. Thank you again to all the guests for joining us at this webinar hosted by TCI, where we talked about the high impact service delivery interventions introduced by TCI to states in Nigeria. You can learn more about these high impact interventions by visiting the Service Delivery Community of Practice on the TCI University. Thank you everyone for joining us.
Great job, everybody. It was great to hear your voices. And thank you so much for sharing your experiences.